Ladies and gentlemen. Good morning, ladies and gentlemen. It is an honor for me to stand before you and to be the first speaker of the day. I consider an honor. I would like to thank ZSOG Scientific Committee for considering our abstracts and giving us this opportunity to present. So I think we have already heard what my intentions are. My intentions are to take you through what we are doing and what we are planning to do in fetal medicine in this country. Oops. Where do I point now? Right. Do I point towards you? Anyway, because it's not moving the slide. I'm already losing time keeper, you can see. So please discount my time. Okay, so, right, oops, I think we are good now. So, thank you. Thank you so much. Right, so the main objective of the presentation is to share with you our pioneering local experience and to also highlight some of the basic procedures we are doing and to inspire collaboration and referrals to the fetal medicine units. The reason why we want referrals is because we want to raise our caseload and multiply what we are doing in the fetal medicine units. And we also want to scale up our services. Through these referrals, we're going to do more and more cases, train more and more people with these cases and try to scale up the services. So, to just give you an understanding of how we work, basically the fetal medicine unit, we have personnel. Now I think we have personnel that range between 50 to 20 who work in the two fetal medicine units. And we are housed at the Perinatal Group of Hospital, Obstetrics and Gynecology Division, and the Salim Gabe Obstetrics and Gynecology Division. That is where the fetal medicine units are housed. Our main mode or our main tool that we use is ultrasound. That's what we use to do our fetal evaluations and also maternal evaluations. So we use ultrasound. And we have a platform where we record our data so that we can look at it and be able to follow up the patients we see. And we work within a multidisciplinary platform, as we see in my other presentation, how we interact with people from other disciplines. Because as fetal medicine, we're cross-cutting. Actually, we're those doctors who are almost everything. When you look at it, we are physicians, we are everything. We cut across every field in our line of work, so that we begin to interact with everyone who works in healthcare. And this is our workflow. Whenever patients are referred to us, they come as referrals. Now we get referrals from everywhere throughout the country. Here and there, we sometimes get some people from outside, but generally we are getting referrals from everywhere now throughout the whole country. Of babies who need our assessment or who need us to intervene on. Then we always assess, double check the suspected condition. Then whenever we diagnose a condition, these mothers are subjected to counseling. We have counselors who have trained over 4 years now to understand fetal medicine and the fetal conditions, because we believe that the subject knowledge is important for tailored counseling. So we work with counselors. Then once there's good understanding and the patient is acceptable, we go on to do the procedure. Depending on what procedure we are doing, then after that we follow up in terms of the outcome so that we know what is happening to the women we have looked after in the unit. Our pre-procedure requirements, our setup is very simple. I think since you are also surgeons in our line of work, one of the few surgeons probably who don't need theatre, because we don't need theater in most of what we do. We can see this is just a simple setup probably for amniocentesis. All we need is an ultrasound scan machine there, a bed where the patient will lie, and those are our things there, where we put some drugs, where the needles that we are going to use. A very simple, non-sophisticated setup that will not require theater. We all agree with me that theater is bothersome. It's hectic to just get theater time in this country. Then we have to confirm the gestational age and the viability, and of course we do a detailed ultrasound to confirm that the lesion or the condition we want to intervene on is indeed the condition. Then we obtain written consent from the mother or the partner. We always encourage partners to come rather than single, for them to come in as individuals. We always fight with our hospital security, because our hospital security are too stuck in some centuries where they believe maternity, no man should go up there. So always fight. We try to tell them fetal medicine doesn't consult mothers, it consult couples. This is very important. Even when you're referring mothers with fetal conditions, always urge them to come to us with their partners. So we document the mother's status in terms of the RESAs, the HIV, the torch, and the anti-D situation. If we need to do prophylaxis, we document that. Then we prepare a semi-sterile field, and we also prepare our ultrasound scan machine. Right now, what do we use? We just put a condom around the probe there. During the procedures, we don't use the probe direct. Then we administer local anesthesia to the mother. Now we are just administering to everyone, even for amnio, we used not to, but we began to see mother experiencing a lot of discomfort even during amniocentesis. So we always administer local anesthesia during the procedure. Then this is our progress. This is what we have, how we have traveled over the years. We can see there that we started just doing amnios in 2019 when we started. Then we brought in amnio drainages. Then we brought in the feticide. Then we are doing pericardiocentesis. And now we are doing intrauterine transfusions. So this is where we are now in terms of intrauterine intervention. We also do some aspiration of cysts as well. So to just take you through some of these procedures, just give you a background understanding of why are we doing them. For amniocentesis, normally amniocentesis for diagnostic purposes for babies with defects. 25% of babies with major defects are associated with chromosomal or genetic syndromes. So as a result, whenever we pick a fetal defect, we need to check if there is an underlying defect. So we do an amniocentesis. It's a procedure where we put the needle under ultrasound scan guidance. We put the needle into the mother's belly, through the mother's belly, right through the uterine wall, and right into the amniotic fluid. Then before we aspirate the first 3 mils, we discard because it will be contained in maternal cells. So we discard the 3 mils, then we take between 20 to 40 mils, depending on the level we are sending to. So what are we using? Right now we are using either the green cannula needle or the 18 cannula needle, which is a 16G cannula, right? So our needles probably are between 18 and 20 G, because we are using the needle part of it to do this. The only challenge we have is that in women of high BMI, sometimes our needle is shorter because it's not long, 9 centimeters long, it's about 7.5 for the grey cannula. So that is a challenge. We sometimes use the spinal needle, but our spinal needles, most of them are small gauge, and they pose as a challenge sometimes. So when do we do it? From 15 weeks. We don't do it before 15 weeks because the amnion and the colon are not fused yet. So there's always a danger of denting the amniotic cavity, and the baby can pop its fingers or its legs through that, and it may result in transverse limb defects. So amniocentesis is not done before 15 weeks. It is very important, right? Because sometimes patients may be referred for amniocentesis at 12 weeks. So we do not do it before 15 weeks. And also the rate of a false of a no result is high because there are fewer fetal cells before that time. And what are we looking for? We are looking for fetal fibroblasts within that amniotic fluid. That's what we'll be looking for. And these will be cultured and be grown and be made to multiply, and they'll be spin to poison for analysis. So, yeah, so we use a single operator technique. That means the person holding the probe is the one who's putting the needle. So then the assistant will aspirate the fluid. Amnio drainage, why do we do it? It's almost the same process as amniocentesis because we put a needle through, but we do it in case of severe polyhydramnios that are either shortening the cervix or causing maternal discomfort. So we also do it in twin-to-twin transfusion syndrome. This is the therapy we are offering in twin-to-twin transfusion syndrome cases at the moment. We are not doing laser. It's part of our Vision 2030, right? Then we are using almost the same things as an amnio. What does it do? It causes maternal relief of dyspnea for those who are now experiencing cardiorespiratory compromise from the excessive distension of the tummy. Then we also reduce the issues of preterm birth. Because one of the things that polyhydramnios does is that it opens or dilates the cervix. So in these women, we do amnio drainage, the cervix recoils. So in other words, we delay the onset of labor. This is one of our patients who was referred to us at 26 weeks with severe polyhydramnios. When we measured, then at first contact, it was almost 15 centimeters, the deepest pool. So we did run some tests. We did a torch. We did amniocentesis with microarray, chromosome microarray, and they all came back normal. Then she came back 3 weeks down the line. The tummy was terribly distended. She couldn't breathe. So we did an amnio drainage where we removed something like 3,000 liters, 3,000 mils, which is 3 liters of fluid. We expected to reaccumulate. The baby had nothing except some slightly echogenic bowels. So we expected to reaccumulate. Alas, it did not reaccumulate to our surprise. It self-resolved. Then this was at 36 weeks now. This woman has since been delivered and she's at home, happy and is home with her baby. Then chordocentesis. Why would you do chordocentesis? We do it in those circumstances where we suspect that the fetus is anemia. We have certain conditions where the fetus bleed, like fetal and neonatal alloimmune thrombocytopenia. We also have the rhesus, isoimmunization, and many other conditions such as parvovirus B infection. They cause fetal anemia. So whenever we think the baby is anemia, we do chordocentesis. How do we do this chordocentesis? We target the cord insertion on the placenta. So we go where the cord is inserted in the placenta through the needle. You can see the needle there, the ultrasound scan probe, and we look for the vein. Then we go into the vein and then we aspirate about 2 to 3 mils of blood. For this procedure, we don't prepare the fetus here. So that's the indication for chordocentesis. We also do it in the setting of amnio intrauterine transfusion. Then pericardiocentesis and cystic drainage. When do we do it? When there's pericardial effusion, severe pericardial effusion. What is severe pericardial effusion? When, if we measure the level of the arteries here, the fluid within the pericardial cavity measures more than 4 millimeters. That's severe pericardial effusion. That is the potential of compromising cardiac output. So, for this procedure, whenever we know we are going to pass the needle through the baby, we do fetal preparation. How do we do it? We give fentanyl 20 microgram per kg and the atracurium 0.4 milligram per kg into the baby's thigh. So we use the spinal needle, look for the baby's thigh, go through the baby's thigh, then give this drug to paralyze the baby and also to give it analgesia because babies feel the pain. So we don't want them to feel the pain. And they also move too much and disturb the procedure. So then we will put the needle directly in the pericardium and aspirate the pericardium until we have done. So this is one of our patients referred from us from very far out of Harare. So she came with pericardial effusion, and we offered, we checked the baby. There was nothing else on the baby. The heart was structurally normal, and we did run a torch. The torch came back normal. And we also did run a cardio here, and amniocentesis with the cardio came back normal. Then we counseled the patient, and she was agreeable to a pericardial synthesis. Then we performed the pericardial synthesis, and this was the post-procedure. We were sent the pictures yesterday, the video at 36 weeks. The baby is perfectly normal, no trace of pericardial effusion. And she's awaiting a pregnancy to go all the way to 10. So that's pericardial synthesis using the same procedure. And then intrauterine transfusion, my colleague will share with you 2 of our cases where we did intrauterine transfusion for rhesus immunization. But these are the indications here where we do it. Sometimes we have these babies who bleed probably from fetal and neonatal immune thrombocytopenias. They are also candidates for this intrauterine transfusion. Again, we prepare the fetus here because the fetus will feel the pain. Sometimes you might want to target the umbilical vein inside the liver, the intrahepatic portion of the umbilical vein. So we prepare the fetus in advance just in case we face challenge at the condensation at the level of the placenta. So how do we do it? We access the umbilical vein at condensation. If not, then we go into the intrahepatic portion of the umbilical vein. This is the preferred because it's quite stable, and we are not going to, because it's well supported by the liver both sides, so it's easier to do it here. But sometimes access is maybe difficult depending on where the baby is dropping, because we are using improvised needles, not the real needles that can reach the baby from any position. So what kind of blood do we use? We use all rhesus negative blood, which is ideally want irradiated. But in our country, our BTS doesn't irradiate blood yet. So what do? We ask them for fresh blood, which is less than 5 days old, and screen for infection, that blood. And we ask them to hemoconcentrate it to 75 to almost 85%. So that's the kind of blood we use, highly concentrated. Then this is how we calculate. When we did our initial transfusions, we didn't have the hemocure machine to check immediately. So we're using a rough formula where we give 20 mils before 20 weeks and then 20 mils for each week gain. So, but this is the formula. Now we have all the gadgets we need to use it. And this is our target hematocrit when we transfuse. So this is, just show you, that's us here performing the intrauterine transfusion, putting it right in the condensation. That's the placenta. This placenta was posterior. I'm sorry, one of our doctors were taking the video, not a professional, right? You see it moving. Stabilization was a problem, but that's the needle. You can see tracking through the baby, going to into the umbilical condensation. That's intrauterine transfusion. The color is being brought by blood, which is being transfused there. So what are the challenges we are facing? Of course, we have shortage of equipment and consumables. Sometimes blood is not easy to come by, the blood which I told you. We actually have to book for this blood in advance, and sometimes we face challenges in getting it. And we also have limited cytogenetic and transfusion capacity. We can now test to whatever level required to test, but the challenge is that these tests we have to send them outside of the country, and they are very expensive, especially for the public setting. So we are limited in how far we can investigate. And I've already told you the transfusion, that getting fresh, hyper-concentrated blood is never an easy task at the BTS. But we want to thank Dr. Berry for his collaboration. He has really been helping us on that regard. Then the cultural and ethical barriers around termination, I'll highlight this more when I do my other presentation. Then we have the funding and training gaps. Of course, we need more people to be doing this so that there is continuity well beyond individuals. Then what we have learned over the years of introducing intrauterine surgery was, I remember when I returned from UK, I was looking for ideal stuff to use, and they were saying I don't have those long needles. When I asked them during one of my trips in Europe, I was told one needle would cost me $200. So I said I can't do them until I said, look, I already have needles here, why don't we use them? So we've innovated locally, and we've also been partnering many other people who have helped us to gain the confidence to do all this kind of work. And we are trying to integrate what we are doing to research and also postgraduate training. We now have our registrars rotating through us, and this is our future, our Vision 2030, which is very tortuous because it's never easy. But we want to introduce these procedures in the coming few years. the intra-atrial myelomeningocele repair together with their pediatric surgical colleagues, and the fetal cardiac intervention, and the shunts, and also the laser therapy. This is what we are looking at. Thank you so much. All right.